it is almost unavoidable to talk about social network because it is through social network uh, we find various sources of help seeking and illness behavior. And among all possibilities within our network, turns out lay referral system is very important. So what is lay referral system? It consists of non-professionals, including family members, friends, or neighbors, who assist individuals in interpreting their symptoms and in recommending a course of action. The course of action. Okay? And a lot of times in help-seeking behavior via network, ethnicity is a very important factor. Okay, and the ethnic influence on physician utilization appears limited to providing a cultural context for decision making within social networks. So still, the ethnic influence is still part of our discussion about help seeking via social network. Okay? And people belonging to close and exclusive groups, so here we're talking about, again, ethnic groups, are either more likely to seek medical care if it is consistent with cultural beliefs and practices, or become less likely to seek medical care if cultural beliefs support skepticism and distrust of professional medicine. Okay. Since we talked quite a bit about social network or influence on physician utilization within network, what is social network? Well, a social network refers to the social relationships a person has during day-to-day interaction, which serve as the normal avenue for exchange of opinion, information, and affection. Typically, the social network comprises family, relatives, and friends who make up the individual's immediate social social circle. Although the concept of social network can be expanded to include increasingly larger units of society. Note that the effect of social network on help seeking is limited, is confined within the following functions: is to suggest, advise, influence, or coerce individual into taking or not taking particular course of actions. Next, let me talk about how social demographic variables affect help-seeking behavior. Help-seeking behavior often involves interaction between several variables acting in combination to influence specific outcomes in specific social situations. For example, age and gender. Let's first talk about age. Use of health services is greatest among the elderly. Older people are more likely both to be physically disabled or ill and to have public insurance coverage, enabling them to use health services more frequently. Okay, and compared with men, women are more likely to visit doctors. Women's reproductive role accounts for less than 20% of all doctor visits, and high visit rates by women are primarily the result of their greater number of ailments. Now let's look at healthcare access and coverage. Okay, since it involves healthcare utilization. Here is this insurance percentage or rates for the non-elderly population by race and ethnicity from 2010 to 2019. Okay, right? So in 2010, for Hispanics and American Indians, they have among the highest insurance coverage rate, right? uh, peaking at around 32%, followed by blacks, right? Non-Hispanic, native Hawaiians and other Pacific Islanders. Then is non-Hispanic, followed by Black and native Hawaiians and other Pacific Islanders. The next is Asians, and the group that has the lowest insurance rates is whites. That's 2010. Okay, then there's a huge dip, and after 2013, probably due to Obamacare or the Affordable Care Act. Here we can see for each group, racial group and ethnic group, there's a major decrease from 2013 to 2015, then stabilizes over time. Then after 2018, there is a slight increase, let's say for, for example, Hispanics, and especially for Native Hawaiian and other Pacific Islanders. In general, there is a major decrease after 2013, 2014 across all major racial groups. And in 2019, American Indians still, along with Hispanics, still have among the highest insurance rates, then followed by Native Hawaiian and other Pacific Islanders, blacks, then whites, and Asians. Okay. And here is another table compiled based on statistics from National Center for Health Statistics in 2019. And here we can see insurance rates for all major racial groups, right? Total in the United States is 10.7%. And for white, non-Hispanic, the number is 7.4. Asians is same 7.4. And American Indians or Alaska Natives have the highest insurance rate of 26.9, 27, right? Followed by Hispanics, 20.36%. And then Black and non-Hispanic population has the roughly second highest, third highest insurance rate. And for a private insurance, whites and Asians, whites have highest private insurance coverage rate, followed by Asians, then is by blacks, Hispanics, and American Indians have the lowest private insurance coverage, because these numbers, they complement each other. So for the groups that have the highest insurance rates, it is not surprising to predict that the same group going to have the lowest private insurance coverage, roughly. Although, Medicare and other public systems also should be factored into the equation, but generally the pattern, looks like that. And talking about the effect of socioeconomic status on illness behavior or healthcare utilization. SES does not influence, only which symptoms are perceived as warranting medical care, with the poor usually ignoring more symptoms, but also the frequency of doctor visits. Okay, so even the poor are equally aware of the symptoms like the rich do, they're still less likely to visit doctors. And people trying to figure out why that is the case. And the first factor here I want to talk about is what is called culture of poverty. That is a phenomenon in which poverty over time influences the development of certain social and psychological traits among those immersed within it. The traits include dependence, fatalism, inability to delay gratification, and lower value placed on health. Like being sick is not especially unusual. It's common to sick, and tends to cultural poverty tends to reinforce the poor person's disadvantaged social position, based on the discussion we just had. And prior to 1970, upper classes visited doctors the most, okay, followed by middle class, with lowest classes visiting doctor the least. Since 1970s, the trend has been reversed. The lowest classes visit doctors the most, followed by middle class, with upper class visiting doctors the least. Okay, poor still do not visit doctors in proportion to actual need for care. They're more likely to have health conditions. Although on absolute terms, in absolute terms, poor still, the poor visit doctors most frequently, but still, not proportional to actual needs. Okay. So why do the poor show lower rates for use of health services than actual need? Dutton tested three possible explanations. First, and all of them actually turn out to be, exerting effects on, of course, healthcare utilization behavior. First is financial barrier, right? And evidence is weak. Medicaid removed monetary barriers from seeking care for the poor. And another theory is cultural poverty. There's moderate support for that. And that is negative attitudes towards medical practices and the willingness to ignore illness is associated with lower healthcare utilization rates among the poor. But there's only moderate support. The system barrier theory provides the most support. So long waiting times, impersonal atmosphere of bureaucracies, difficulties locating and traveling to particular sources of care, and poor patient physician relationships translate into reduced medical care.